In today's society, smart healthcare has been closely integrated into our healthcare system. When deploying smart technology, where do we find solutions that meet needs? The answer is Health Smart Taiwan. Its extensive service modes provide the latest industry R&D news, in addition to abundant case studies and solutions. HST selects smart healthcare applications that were awarded the National Healthcare Quality Award and incorporates diverse smart healthcare demo sites. HST displays the efficiency of Taiwan's smart healthcare applications. As an industry solutions for healthcare issues, cross-field integrative platform, HST is able to solve key challenges and difficulties of healthcare institutions. HST, your answer to smart healthcare and cross-industry cooperation. In today's society, smart healthcare has been closely integrated into our healthcare system. When deploying smart technology, where do we find solutions that meet needs? The answer is Health Smart Taiwan. Its extensive service modes provide the latest industry R&D news, in addition to abundant case studies and solutions. HST selects smart healthcare applications that were awarded the National Healthcare Quality Award and incorporates diverse smart healthcare demo sites. HST displays the efficiency of Taiwan's smart healthcare applications. As an industry solutions for healthcare issues, cross-field integrative platform, HST is able to solve key challenges and difficulties of healthcare institutions. HST, your answer to smart healthcare and cross-industry cooperation. In today's society, smart healthcare has been closely integrated into our healthcare system. When deploying smart technology, where do we find solutions that meet needs? The answer is Health Smart Taiwan. Its extensive service modes provide the latest industry R&D news, in addition to abundant case studies and solutions. HST selects smart healthcare applications that were awarded the National Healthcare Quality Award and incorporates diverse smart healthcare demo sites. HST displays the efficiency of Taiwan's smart healthcare applications. As an industry solutions for healthcare issues, cross-field integrative platform, HST is able to solve key challenges and difficulties of healthcare institutions. HST, your answer to smart healthcare and cross-industry cooperation.
Ladies and gentlemen, welcome to International Smart Hospital Leadership Forum 2021. If any question based on presentation to our speakers, please type those in question box and Slido. Also, we have 4 speakers. Please specify which speakers or department their questions are for. After the presentation, those will then be raised up and discussed. Thank you for your cooperation. Good afternoon, ladies and gentlemen. Welcome to the first session of International Hospital Leadership Forum 2021. As one of the highlight forums of Smart Healthcare Expo, today's event is organized by Joint Commission of Taiwan, Taipei Computer Association, and Taiwan Smart City Solution Alliance, and supported by Asian Society for Quality and Healthcare. This forum is an excellent platform for healthcare professionals, as well as field researchers and practitioners, to present innovative solutions and to discover the latest trends in the smart healthcare market. We're excited to invite leaders and experts from prestigious hospitals, universities, and smart healthcare businesses to discuss the topic. For our speakers, please turn on your cameras and wave to audiences. Thank you. Now, let us introduce our distinguished guest. Join us. Please welcome Dr. Chi Zhenling, President of Joint Commission of Taiwan. He will be our moderator for today's session. Next, let us welcome our speakers. Dr. Karen Larsford, CEO at Australia Council of Smart Care Standards and ACHS International. Mr. Liu Qinghuo, Deputy Director at the Center for Intelligent Healthcare, National Taiwan University Hospital. Mr. Len Park, Attending Physician from Division of Psychiatry at the Lansing International Hospital. Dr. Xian Liu, Director at the Center for Quality Management, Taichung Veterans General Hospital. Thank you and welcome. We'll now take a virtual group photo to capture this special moment. I would like to invite all our guests to look in the camera, raise your thumb and smile when we take a screenshot. Ready, set, smile. Thank you for joining the group photo shooting. With so many professionals in the field, today's forum is certainly expected to be enlightening. To kick the forum, Dr. Chi-Jun Lin, President of the Joint Commission of Taiwan, will deliver the opening remark. Dr. Lin is the distinguished professor at the National Tsinghua University, as well as the attending physician, serving the Department of Orthopedic Surgery, National Tsinghua University Hospital. Please join me to welcome Dr. Chi-Jun Lin.
Hello, everyone. Welcome. Thank you for joining us for today's webinar. My name is Chi-Jun Lin, the President of Joint Commission of Taiwan, JCT. JCT is in charge of nationwide hospital accreditation in Taiwan, postgraduate year training program, and the healthcare quality improvement. For examples, by hosting the annual campaign of National Healthcare Quality Award, NHQA, we encourage hospitals to initiate technology resolutions in healthcare services and demonstrate the smart solution to the international community. A Health Smart Taiwan, HST, operated by JCT, is dedicated to promoting the cross-industry integration of healthcare and technology, driving healthcare innovative services, and enhancing the value of smart healthcare solutions. In the post-epidemic era, HST would like to support healthcare and the MedTech leaders to equip with resilient ability to face the waves of impacts from external environment. Keeping the goal in mind, HST organized the virtual forum focused on the new care models of digital delivery and resilient operations. Today, on session 1, we will talk about the new care model of digital delivery. During the next hour, Dr. Karen Larsford, CEO of Australia Council on Healthcare Standards, ACHS, and the 3 healthcare leaders from NHQA hospitals in Taiwan will share their own expert insights on telehealth. Again, welcome to join the virtual forum with the high esteemed international expert, healthcare leaders, and the MedTech pioneer worldwide. By bringing the 2 most thriving industries in Taiwan together with the international perspectives in healthcare renewal, we intend to provide the international vision and the practical suggestion to assist leaders in implementing a resilient recovery in building sustainable healthcare environment. Now, let us turn the time over to our speakers.
Thank you, Dr. Lin. Now we are excited to welcome our first speaker today, Dr. Karen Larsford. In her presentation, she will talk about quality standards for telehealth. Dr. Luxford is the CEO of Australia Council on Healthcare Standards and ACHS International, and the board member at ISQua, Asian Society for Quality in Healthcare. Please join me to welcome Dr. Karen Larsford.
Hello, everyone. My name is Dr. Karen Luxford. I'm the CEO of ACHS and ACHS International. I'm very excited to be a part of this Smart Health Leadership Forum today. Bear with me for a second while I just share my presentation slides with you. I'm going to be talking about quality standards in telehealth. And this has been an enormous time of change for all of us in the last year and a half. And we have seen many developments in the area of telehealth, and certainly the changes have been exponential. And so I'm going to share with you the experience of ACHS International in terms of telehealth standards in our accreditation approach, and to hear from one of our customers who has recently been accredited to accreditation in telehealth services. Our really big focus is on being a quality improvement partner to hundreds of healthcare organisations, and we have a focus in the Middle East and in the Asia Pacific, and we are focused at present in 15 different countries. We've got offices in Dubai and in Hong Kong, and we are absolutely influenced by the great things that the Australian healthcare system is able to achieve. Our services are focused on quality programs, clinical indicators, consulting, training and education. And we distinguish ourselves in that partnership with our members on their quality journey through coaching, quality partnership, membership portals, forums, and a range of events. In overview today, I'm going to talk about the rise of telehealth, telehealth accreditation, then share with you a member story and wrap up from there. And I know that at the end of this session, after a range of speakers, we will have some time for questions and answers. So in this period that we are all experiencing with the COVID pandemic, we have certainly seen many changes, and telehealth is one of those big changes. Many of us will have had telehealth happening within our countries, but we have seen a massive uptake in telehealth. And I wanted just to start with a definition, which is really around telehealth being the delivery of healthcare that uses information and telecommunications and can be transmitted via audio, via image, or data between a patient and the healthcare provider. So telehealth can be used for diagnosis, can be used for treatment, prevention, or curative aspects of healthcare service delivery. And in terms of the consultation itself, it can be synchronous, delivered in real time, or asynchronous, delivered not in real time. So an example of that would be with synchronous delivery via the telephone or video, or asynchronous might be, for example, an email or a secure messaging system. We've certainly seen here in Australia the massive increase in remote monitoring, and many of the people who have experienced COVID may have actually spent time at home being monitored using remote monitoring to check on vital signs. And this has been a fabulous development, keeping people out of hospital if they don't need to be there, hopefully making sure that they do go to hospital when they do need that care. And so communications with telehealth can be provider to provider or provider to consumer or patient. So here's some data from Australia. What we have seen in this pandemic period was we did have some very minor use of telehealth, and this data is from primary care, from general practitioners, but you can see come March 2020, where the federal government in Australia introduced a reimbursement scheme for telehealth, massive increases. People were wanting to stay at home and not be out in the community. And so those numbers you can see with the grey columns just completely go through the roof, and there's been a huge exponential increase. And what we've seen is mostly phone consultations in the Australian environment, some video usage, but overall total consultations equaling 2019 numbers. What we've seen a decrease in is in referrals and in pathology, and for example, in tests for diabetes like HbA1c. What I'm concerned about is what is that going to mean in the future? The referrals to specialists dropping off may mean that people have not been following up on critical issues other than COVID, and we may see some of the ramifications of that a bit further down the track. So with the introduction of new tools, we need to make sure that the system is still as safe in providing the quality of care that needs to occur. So the telehealth is a means of transmission, and we need to think about what is that impact on clinical safety and quality. Is there the potential for over-servicing? Is it going to actually increase expenditure or decrease expenditure? And is there going to be duplication or uncoordination of services? Making sure we've got equity of access is still critical. And standards for the use of technology in the way it should be used in a safe and quality way to make sure that we are still supporting our patients with privacy of their data. So ACHS International is very excited to be able to provide services with Telehealth Standards, and these are built on our EQUIP program, and we are working on the release of EQUIP 7 coming up soon. And we have specific areas of the standards that are related to telehealth provision. And the telehealth in particular needs to be able to cover specific requirements within the standards. Consent, critical, ensuring that consent is clear and captured through the telehealth consultation. Privacy, making sure that as an organisation and a health service you have policies around privacy and data storage of patient information. Medication, making sure medication reconciliation and prescribing is adjusted. I experienced this myself just recently with a telehealth consult with my own general practitioner, where the medication script was actually sent remotely to my phone. I could then go to a pharmacy and actually use a QR code to download a script. And equally, capturing the outcomes of patient care based on telehealth services and treatments. So Telehealth Accreditation is involving a comprehensive assessment and making sure that we support the implementation and continuous quality improvement by our members. So the overall standards are looking at the structure. Have you got the right policy, procedures, education, governance and technology in place? The process, how is that implemented? What is the care delivery process, and are you getting feedback? And what is the outcome? Is that being assessed, evaluated? Are you improving, and how are you engaging with your patient community? So the telehealth cycle is over a 3-year membership, and that's important because in each year we have an improvement event. So, for example, in the first year, in the first year, an organisation-wide assessment. Second year, a focused advisory checkpoint. and similarly in the third year. So making sure that there is a continuous focus on that improvement rather than the roller coaster that we often see with assessment and accreditation, where people may sort of ramp down and take their foot a bit off the brakes. We want to make sure that safety is the focus every day, and equally with telehealth. So I'm going to share with you now a member story from ACHS International, and this is from the Prime Hospital in Dubai, and we accredited in this year, in 2021, their telehealth services. They shared with us their story, and I'm just going to play this short video so that you can experience their feedback for yourself.
At Prime Hospital, Dubai, we believe that telehealth service provides access to care and continuity of care to our patients, which are two important quality dimensions in the continuous journey of quality improvement and patient safety. With ACHSI, we connected with the global experts to get their suggestions and recommendations on quality improvement initiatives. Example, to enhance our medical record with screening tool on patient safety standard to ensure that Prime Hospital provides the best care to our patients.
ACHSI is a world-leading healthcare improvement organization where we partner with different global healthcare providers to improve patient safety and quality of care. As you know, in the past year, COVID-19 started to impact our ability to interact with patients in person and keep everyone safe. During that time, Prime Hospital continued focusing on safety and quality in a new care delivery method like telehealth. To ensure they are providing high quality of care through the telehealth services, they achieved the ACHSI Telehealth Accreditation.
Prime Hospital is an international compliant telehealth service provider for greater reach, easier, faster, and safer access, improved patient outcomes, in addition to cost saving. Traveling to the doctor and waiting in this pandemic period for an appointment considered a health risk compared to previous COVID times.
We've been using telehealth services at Prime Hospital for more than a year. I would like to talk about the advantages of telehealth services. First, from the perspective of the physician, it helps us pre-screen patients with infectious diseases, especially COVID-19, and decide on advising them to stay at home if they are stable. Medicines would be delivered to their doorstep. This actually prevents the sick patient from coming to the hospital and infecting other patients, and also reduces the risk of secondary infections for the sick patients. Another thing is chronic medical conditions like diabetes and hypertension. Patients who have these conditions and who are stable can get telehealth consultation and update the doctor regarding their health situation and medicine refill, thus preventing them from coming from the hospital to risk for infections.
Nowadays, all insurances cover telehealth services, and also we have net promoter score more than 70%, which consider a global benchmark.
From the perspective of the organization, it increases the access to healthcare by reaching out to more patients. It reduces the no-show rates in hospitals. It reduces the overhead cost per visit, is less time-consuming, and improves the overall quality of healthcare.
Fantastic to hear about that experience from Prime Health, and we were certainly very excited to be able to accredit their services. So just in conclusion, there is a lot of information out there around telehealth. Here are some examples of resources that have been available in the Australian environment through Queensland University, a telehealth quick guide, through one of our states, Victoria, telehealth decision tools, and our own Equip 7 telehealth guide from ACHS International. So I'm hoping that you have found this interesting, thinking about your own use of telehealth and making sure that your service is keeping safety and quality at the absolute forefront. We'd be delighted to talk more to you about our work and to hear about what you're doing in telehealth as well. Thank you very much for your time today, and I look forward to your questions later in the session.
Thank you, Dr. Luxford, for your presentation. Next, I would like to invite Mr. Untitled to deliver the next presentation, Patient-Centered Seamless Transition and Referral System. Mr. Guo is the Chief of the Information Management Section, Referral Management Center, and a consultant in both Center for Quality Management and Medical Information Management Office at National Taiwan University Hospital. Please join me to welcome Mr. Untitled.
Ladies and gentlemen, I'm Dr. Guo from the National Taiwan University Hospital. It's my honor to be here to present the Patient-Centered Seamless Transition and Referral System, abbreviated as P-STARS. I'm a medical doctor, a physician of the Department of Internal Medicine, and I also work in the hospital, in the Center of Intelligent Healthcare, in the Information System Office, in the Referral Management Center, and the Center for Quality Management, and in the Medical Information Management Office. First, I will show the outline of my talk. First, I will talk about the background and make an introduction to my hospital, and I will talk about the unmet need we met, and then I will introduce the referral platform, and then the conclusion and future prospects. As you might know, that my hospital, National Taiwan University Hospital, is a public university-based tertiary medical center at Taipei. It was founded in 1895 and has more than 120 years history. It is regarded as the best hospital and medical center in Taiwan. The hospital has one main hospital and 6 branch hospitals around Taiwan. In the main hospital, as you can see here, there are more than 7,000 employees, including more than 600 attending physicians and 600 residents, and there are more than 3,000 nurses. There are about 2,200 inpatient beds. As the statistics shows here, you might know that the hospital is very busy in the inpatient, outpatient, and emergency services. In Taiwan, there is a nationwide system called National Health Insurance System. It includes all citizens. That means all citizens could and should join in the health insurance system. And in Taiwan, the majority of hospital and GP clinics also join in the health insurance system. The citizens or the patients only pay a small amount co-payment, and the accessibility of this hospital and clinical system is very excellent. In the medical system, there are 4 levels of health providing organizations, including medical center, regional hospital, district hospital, and GP clinics. The current status is that the citizens and patients can go directly to any hospital, GPs by their own. Although there is a little difference in the copayment, that means the patient must be paid a little bit more if they go directly to the medical center without referral. Because the copayment is only a little difference, many patients favors to go directly to medical center or emergency services, even the disease or symptoms are minor. We made a lot of efforts to encourage the patient to visit GPs first, especially when their symptoms are minor. Although there are regulations of the referral system, of the health insurance system, and we made many efforts to make patient education, there are only limited efforts. Patients do not accept a referral system very well. Then I will talk about the hospital information system, abbreviated as HIS. In Taiwan, every hospital has its own hospital information system, and most of the systems are developed in-house. That means the hospital made their own system without the support from outside resources. That means there is no huge vendors such as Epic or Cerner systems in the United States. And for the GPs and clinics, they use one of the major 3 vendor systems as their information system. Because the hospital and clinics use different systems, the exchange between hospital systems are very difficult. There is only limited to a few sheets, for example, the discharge summary or some outpatient records via the exchange service set up by the government. And also, there is no standardized format, for example, the file format at present. That means the exchange between hospitals are very difficult. As a viewpoint of a physician, there are many unmet needs. First, through current referral system, only a refer sheet available for the communication between physicians, and it is always one direction information. There is no detailed medical records available, and it is difficult for the 2 sides to make two-way communications. And the second is that we have made an extensive efforts to make appointments for the clinics. It is inconvenience when they are in the GP clinics. And for my hospital, there must be a lot of extra administration work for this appointment issue. For the above reasons, we want to create a patient-centered care system to resolve the above problems. We call it Moon and Star Project. The moon is the patient. That means a patient-centered. And all the hospitals, including my medical center and local hospitals and GPs, are all stars surrounding the patient. So we want to create an integrated platform to facilitate the referral process. In the platform project, we have several stages and goals. We want to establish the patient-centered referral system based on the information platform. First, we establish a consortium. That means we recruit many hospitals and GP clinics to join our consortium. And second, we create an information platform. And then we want to set up a smart care guideline for the physician and patient. We believe that by these three processes, the referral system will be better. Among these, the IT support is crucial. We have a strong IT team in our hospital to create the system. As you can see here, start in 2018, we recruit more than 400 GP clinics and local hospital at Taipei City and New Taipei City. And in 2020, the number of hospital and clinics grows more, and we extend our district to Yilan County, a nearby county. And in 2022, we plan to recruit more than 100 clinics and local hospitals in the consortium. These are the purposes of the platform. Actually, it is an extension of the hospital information system to the GPs. We will let GPs to go directly to our system to see, to use the patient informations. To facilitate a seamless patient care, we could share our medical records with the GPs, and it could eliminate duplicate medications and examinations, and it will save more medical resources. As you can see here, GPs could access the information platform to make appointments, and they will receive the telephone messages or emails in some conditions, and it could make bidirectional communication with our hospital physicians. The security is most important because the patient data is very private and sensitive. We must protect these sensitive informations. So, the GPs can only access the patient they refer to or from our hospital. They must log in with their individual ID and password to this system. Actually, they have to use a certificate IC card that was a physician's certificate card issued by the government. So they should put in the card simultaneously to log into our system. And in the system, we have many privileges control mechanism, and we have detailed log, and so we can trace which doctor viewed which patient's records. The target user of this platform includes the my hospital physicians, and second is GP, and third is a patient. In my hospital physician, the system will give some reminder for the referral. For example, the patient was referred from which local hospital or clinics, and the platform will facilitate our physicians to make a seamless transition referral. And by this system, the doctors could find consortium clinics and physicians by the patient's address. That means the doctors can search the clinics nearby the patient's home. And then my doctor could make bidirectional communication with the GPs. For the GPs and local hospital doctors, they can make appointment to our hospital by this platform, and they can see the medical records of the patient in this hospital, and they can trace and track the patient's referral status, and they can get an administrative reports from this system. They can make bidirectional communication the hospital doctors, and also we have a continuing education platform for them. For the patients, we develop an app for the patient. They can locate the GPs by the map. They can see what GP clinics, hospitals is joined with our hospital, and they can find the physician's subspecialty. And there was many education documents for them. This is a platform screenshots. On the left is that the referral patient list for each physician. That means the physician can only see the patient they refer to our hospital, or the patient our hospital refer to them. Other patients' data was not available here. After they select a patient, they can see the medical records regarding the referral here, including the outpatient records, inpatient, summary operation note, laboratory report, examination report, medication list, etc. So they can see how the patient was diagnosed and treated in our hospital, and they can see the reason why the patient was referred back to them. About the information of appointment, the GPs could make real-time appointment for their patient. The time is in the future 1 month, and the quota is reserved for the referral only. It will not occupy by the other appointment resources. And they can get some information about the referral status, get by the telephone message or by the email when the patient visits our outpatient department, when the patient was admitted, discharged, or when the patient was referred back to them. When they get this information, they can log into the platform and see their patient condition immediately. About the communication between my hospital and the GPs, we have an online communication system, and you could both doctors could communicate via this platform. For the doctor in my hospital, this is a reminding systems, including some reminding in the inpatient system, outpatient system, in emergency system. And by this platform, the doctors could very easy to refer back the patient to the GP. And we create a map for the doctor to search for the GPs near the patient's home. As you can see here, the patient address input here, and then it will show the nearby GPs and hospitals. This is an app for the patient. It is multifunctional. The referral system information is over here, and the patient could search for the GPs within the consortium with my hospital, and it was displayed in the map, and then can make communication directly to the GP. By this system, you can see that the referral number increased. This is a number of a patient referred to our system increased after the project started. The number referral from our hospital was dramatically increased after the project started. In summary, by this platform, we achieved the goals of paperless and achieved the goal of medical record sharing and communication for simulation referral. And in the future, we want to make connection between the hospital information and GB system. That will be our future work. Thank you for your listening. Any comments or questions are welcome, and we'll have a discussion later. Thank you.
Thank you, Mr. Kuo, for your sharing. Our next speaker, Mr. Lim Park. Today, he is going to deliver the presentation on lengthy telehealth for anxiety and depression during COVID-19 pandemic. Mr. Park works as an attending physician at Division of Psychiatry, serving the Lindsay International Hospital. Meanwhile, Mr. Park is also a lecturer at School of Medicine, Fujian Catholic University. Let us welcome Mr. Lim Park.
Good morning. I'm Dr. Brian Lam, psychiatrist. I'm working from home. You may wonder, how could a doctor working from home? Taiwan Lansing Hospital, the most modern and premier hospital in Asia. Each day we have to face working with many patients in the hospital. Until the days come, the social distance and quarantine become part of our life. Patient fears to go to the hospital. Government announced the policy of keeping people around for nights. This brings difficulty of medical service. Especially, more and more people get more stress and provoke psychological issues. Our chief, Dr. Chen, heard the call. He brings up the idea of using modern technique to solve the problems. We first start directly by using the connection with patient by mobile phone directly. We were so naive to believe this was the simplest, effective way. Practically, the outcome was not good. A lot of technical issues arise. Poor audio issues, poor visual transmission in the video interview. In the first day of our online interview, 75% patients have problems in using the software, such as no voice, delay entering the charge room, poor vision due to the poor lighting in the house. The surrounding environment is too much noisy that reduces the quality of the interview. Children running around and interrupt the conversation. All of those problems that you can imagine come to the practically in the real world. You can't believe that I spent 18% of my time in solving the technical issue instead of the medical issue. I felt myself like an IT man other than a medical doctor. Each day, I felt very exhausted, even after there is 10 patients in 3 working hours. In the end of each session, we discussed with 3 IT staff to solve the bug in software and make it more user-friendly after working together in more than 10 hours each day. At the 10th day, our online consultation became more smooth and less obstacle. However, some new issues arise, even though we solved the software bug and modified it to a more user-friendly way. However, the patient side was still facing a new technical difficulty. The first simple but annoying problem was the audio issue. We tried a lot of methods and finally found out that using a cheap microphones worked out perfectly. However, in the real situation, patients forget to use it frequently. Even though we post the announcement in the first page, 35% patients still forgot the microphone or earphones when we request them to use it in each session. It wastes us a lot of time to wait for them to pick it up and even searching the whole house for an earphone. Each patient spending 3 minutes for searching means we're wasting 19 minutes in the 3 working hours totally. Weak signal and bad web network connection was really a serious issue. Can you imagine how frustration when you can only hear the broken sentence of the key symptoms that you need to collect important data from patient in the interview? When facing this situation, patients need to move all around their house to find a good site to receive the good signals in order to have a good connection. We post the important notice of finding a good site to receive a good signal again. Still, 20% patients, including many elderly patients, missed the point. Many other doctors couldn't tolerate the great obstacle in the process and set limits to the available of the telemedical service. At this point, our boss backed up us to get through it strongly. And this is really important when you can facing a frustration in the process. Our chief of Lansing Hospital told us the future is now. Telemedicine is the future and must work out at the same time we find out. Telepsychiatry service, which we call TP, really has a lot of advantage to our patient, especially the one that do not have insight about their mental illness. Strictly speaking, 17% of mental illness patients have great resistance to achieve their out service due to the stigmatization of psychiatric illness, so the TP could provide great help to this unreachable patient. This means the using of TP is also the future of the psychiatry. The timing is now, and we have to break through it. Surprisingly, our persistence providing the TP service had an unexpected outcome. We decreased the loading of the emergency psychiatry service. Many mental illness patients was early discovered in the use of the TP, especially with those of psychotic patients. They always spend most of their time for cover up their paranoid idea. However, the family could use the mobile phone camera to shoot their bizarre behavior as an evidence for the psychiatry doctors in the TP. This makes breakthrough with the help of the early detection of the poor symptom of the psychotic patient. We could adjust the medication immediately and handle the explosive psychotic patient. After using of more than 30 days of our TP service, we find out that 40% of the relapse of psychiatric patients decreased 40% and preventing psychiatric hospitalization. When I shared this experience with our colleagues, they were greatly surprised by what we did. And more TP service was available in order to decrease the loading of the hospitalization. The payment of the central government in the psychiatry service decreased 15%. This is a quick lead in the child psychiatrist also. You could understand how it is difficult to bring a young child to a psychiatrist OPD, especially the child who was under 6. But with the use of the TP, we could view the behavior of the disturbing child in the home from the mobile phone camera. We could accompany and support the helpless parents, suggesting behavior modification to the helpless parents at the same time. In this day of distant learning, many students need to spend more than 6 to 8 hours of home. This was a great distress to the student and the young people. Family violence case increased 30 to 40% in this day of quarantine. With the help of the TP, we solved the family issue fast and quickly. in the day of Freud. They never think about the modern network could bring a great achievement to the management of the human behavior struggle. Another great access to mental health was those in rural areas. In the past, they have to spend more than hours achieving psychiatry hospital. Now we assess the patient directly, immediately, even 100 miles away. Many psychiatry patients get ready great improvement in the prognosis after we use the TP. In the future, we strongly suggest the central government keep on TP service in the future, because this saves a lot of life and always save a lot of money. After providing the TP service for more than 40 days, we find out the simple solution to solve the great difficulty in the patient side technical problems. As we mentioned before, patients always forget to put on the earphone device and find a good place for network connection before any session. Now, we will spend only 10 minutes before the session. A technical staff will call each patient by using only 1 minute to ask him to put on their phone device and find a good place for connection just 30 minutes before our session. This solved the problems. And we are so encouraged at the end of this speech. We would really appreciate our Chief of Hospital, Dr. Jen. We would not have the great success of the TP without his help and encouragement in this state. We hope more and more psychiatrists would use the TP to provide the service in the future. Thank you very much for your listening.
Thank you, Mr. Park, for your presentation. And now, please join me to welcome our last speaker today, Dr. Xian Liu. Dr. Liu is Minister of Education, Certificate Professor, Faculties of Medicine at Schools of Medicine, National Yangming University. Moreover, Dr. Liu is also the Deputy Director of Department of Otolaryngology, Taichung Veterans General Hospital. For his presentation, he will share with us Separation Without Distraction, Remote Application with Care. Please welcome Dr. Xian Liu.
Ladies and gentlemen, it is our great pleasure to share the experience of Taichung Veterans General Hospital with you. The topic is Separation Without Distraction, Remote Application with Care. I'm Xian Liu, Director of Center for Quality Management of Taichung Veterans General Hospital. Here I do express my sincere appreciation to our entire colleague that involved in this project, as this is the result of highly cooperative teamwork by all of them. This is the outlines of today's presentation. We will briefly review the history of telemedicine. Then we will share the experience of our hospital. Also, we will present preliminary results of our project, then into our conclusion. In 1998, World Health Organization proposed their definition of telemedicine. That is, the delivery of healthcare and the exchange of healthcare information across distance. It included the whole range of medicine, including diagnosis, treatment, prevention of disease, continuing education of healthcare providers and consumers, research and evaluation performed when distance is an issue. This is probably the first literature addressing telemedicine. It was published in 1992, nearly 13 years ago, from journal Hospital Community Psychiatry. The author outlined some pioneer telemedicine programs of the 1960s and the 1970s and described two previously activated systems in Texas. One network serving the western 2/5 of the state, links faculty members from 4 campuses of Texas Tech University Health Science Center with almost 14 rural communities. The other connects the state hospital and the 3 other facilities in Austin with 4 healthcare sites in the town of Giddings, 65 miles away. Besides serving patients, the systems provide continuing medical education and support to reduce the isolation of rural healthcare professionals. Primary goals including evaluation and the certifications of telemedical training and the analysis of the cost feasibility of telemedical services. The author concluded at that time that telemedicine is still a relatively new area of interest, and while the technology is rapidly evolving, changing, and fascinating, it is still the human factors that tend to determine the success or failure of the telemedicine project. They also find out that most early telemedicine programs did not continue after grant funding ended. As a result, this seldom seems to be translated from the initial project leaders to other clinics, and few systems seem to have a real consumer, user, or outcome focus. This is the base for evolution of telemedicine, World Wide Web, space medicine, and the telemedicine for airline passengers and the seafarer. The US military developed the idea for a national network of computers in the late 1960s. The Advantage Research Project Agent was an experimental network of computers designed to support military research and protect information that could be destroyed during the bomb attack or natural disaster. ARPANET's successor was created in the 1980s by the National Science Foundation. 5 regional supercomputer centers around the US were connected to form the backbone of the Internet. To expedite research for an ongoing project at CERN Laboratory in Geneva, Switzerland, consulting software engineering team Bernard-Lee developed a system to link documents stored on various computer systems and make the Internet's huge knowledge base easily accessible. In 1991, Bernard-Lee's program, the World Wide Web, was introduced on the Internet, which in turn to connect the whole world with a finger nowadays. NASA has been a pioneer in telemedicine research and application. Since the first stage of suborbital flight, telemedicine has been transformed by the increasing complexity of space operation. Today, telemedicine capabilities go far beyond monitor healthcare. The remoting monitor of crew, a spacecraft, and the environmental health can always be an integrated part of the NASA's operation. There is no doubt that COVID-19 represents not only the most dreadful contagious disease, but also the biggest public health event in the 21st century. The outbreak of COVID-19 leads to extensive transform of the healthcare system worldwide. In addition, it accelerates the development of telemedicine. Monitoring patients in their home can lead to better healthcare at lower cost, which implies an increased demand of new healthcare strategy. Our team members include, this is Taichung Veteran Hospital's experience. Our team members includes IT companies such as Guangda Yanhua Company. We also work with Academia Sinica, which is the highest research institute in Taiwan. Zhonghua Telecom, which is the largest telecommunication corporation in Taiwan. The leader is our superintendent, Professor Chen. TCBGH has a smart medical center, which cooperates with IT department, ICU, neurology department, cardiovascular center, and the Department of Family Medicine to develop a network connecting veterans hospital and the veterans home. Thanks for the recent advancement in the 5G technology. It is faster than traditional 4G transmission. It also provides a safer, minimal delay and high-speed exclusive network connecting TCVGH, Veterans Hospital, and the Veterans Home. Now we'll share with you our experience in telemedicine. We separate into communication among TCVGH, Veterans Hospital, Veterans Home, and the application inside the hospital. We report 3 cases to represent our application of telemedicine. First case, a 65-year-old gentleman who is jogging with his wife in the afternoon in a sunny day. However, sudden onset of right side hemiplegia with aphasia was noted by his wife. He was brought to emergency room of Puli Veterans Hospital immediately by 911. He has past history of hypertension with irregular medication. Stroke was suspected by triage. Duty doctor was informed immediately. Sorry for not translating into English. I will explain briefly. There was no neurologist in Puli Veterans Hospital at that time. Therefore, Puli initiated stroke telemedicine protocol immediately. That is, nurse in charge of Puli Veterans Hospital connected a neurologist in TCVGH at the same time. Brain CT, EKG, lab study was arranged by duty doctor in Puli Veterans Hospital. Brain CT scan review by the emergency room doctor excluded the possibility of intracranial hemorrhage. NIHSS score of the patient was assessed thereafter and reviewed 21 points. Also, there was no contraindication for RTPA injection. Then, emergency room doctor of Puli Veterans Hospital initiated telemedicine for video meeting with TCVGH. When TCVGH neurologist received the message sent by Puli Veterans Hospital, the duty doctor opened a telemedicine card to meet with ED doctor from Puli Veterans Hospital. They reviewed the brain CT image together as well as relevant examination reports. After detailed discussion, they decided to undergo RTPA therapy. The patient recovered well after this telemedicine protocol. Puli Veterans Hospital located in central Taiwan, that is, near geographic center of Taiwan Island. Lack of medical resources is a problem of rural region of Taiwan as well as Puli Veterans Hospital. It is short of neurological doctors. As a result, no routine RTPA treatment in there. However, hospital still has the social responsibility. Being the only public medical center in central Taiwan, TCVGH should promote the ability of Puli Veterans Hospital. The most important thing is that time is brain. We should try our best to preserve the function of the brain. If the intervention duration can be shortened, the brain function preservation will be better. Furthermore, TCVGH and the Puli Veterans Hospital is always connected. This is the real situation during telemedicine video meeting. Picture over left side represents doctor in Puli Veterans Hospital evaluating the stroke patient. On the right-hand side, neurologist in TCVGH can work with the Puli in reviewing the image and the lab study. Neurologist in TCVGH also can see the patient and give suggestion to the doctor in Puli Veterans Hospital. Our second patient came from Chiayi. A 43-year-old gentleman was driving his car in the highway near Chiayi City Sunday evening. Sudden onset of chest pain and dyspnea happened. He was brought to emergency room of Chiayi Veterans Hospital immediately. Pre-hospital EKG by 911 found suspect inferior AMI. EMT called Chiayi Veterans Hospital and the heart-saving team was informed. By the time of 18:11 p.m., the patient arrived at emergency room of Chiayi Veterans Hospital. Cardiologist and the heart-saving team already stand by at the emergency room. Heart-saving team initiate when they knowing there is an inferior wall AMI patient coming. Go-to balloon time is less than 19 minutes. Interventional cardiologist found lots of blood clot in coronary artery, and it is hard to remove by traditional methods. Cardiologist try to use angiojet. However, he is not so familiar with this technique. Therefore, he initiated AMI Telemedicine. TCVGH senior cardiologist receives online message and initiate a telemedicine video meeting immediately. TCVGH senior cardiologist tutors Chiayi Veterans Hospital's doctor how to operate angiojet, and the blood clots were all removed. Nevertheless, the circulation is still poor. TCVGH's doctor tell Chiayi to arrange cardio echo and suggest larger stent placement. Finally, this patient recovered well after this telemedicine protocol. This is the real situation during telemedicine video meeting. Picture over left side represents doctor in Chiayi Veterans Hospital performing CAS operation. On the right-hand side, our chairman of Cardiovascular Center, Professor Lee, in TCVGH can work with the Chiayi in reviewing the operation procedures. The third case came from Zhanghua Veterans Home. A resident of Zhanghua Veterans Home just discharged from TCVGH due to pneumonia. He has some problems with his medication. Doctor of Zhanghua Veterans Home initiated telemedicine for medication consulting. Doctors of Family Medicine in TCVGH was contacted to help reviewing the medication. Also, recovery after discharge, medication compliance along with integration, nutrition, further care can be evaluated by doctors of family medicine in TCVGH. Such telemedicine consultation can reduce the use of multiple and inappropriate drugs as well as eliminate unnecessary clinical and emergency room visit. This is the real conversation between doctors of family medicine in TCVGH and the doctor in Zhanghua Veterans Home. TCVGH's doctor says, "Mr. Gore, are you okay after going home? Is there any fever or sputum?" Request Veterans Home's Dr. Chen about the compliance of medicine, reviewing medication list. Veterans Hospital doctors say, "Mr. Gore's condition is good after going home, but there are medications from Meta chest medicine GU in need of integration." TCVH's doctor says, "Its partial medication is not suitable for the elder. Medication can be reduced from 12 to 8. I will also give health education about oral hygiene, chest care, and the bedside rehabilitation to Mr. Gore." Mr. Gore was happy about this telemedicine consultation, so as doctor from Zhanghua Veterans Home. This is the real situation during telemedicine consultation. Here we present a short video for you. Dr. Chen, can you show us the patient's eye? TCVGH doctor will tutoring doctor from Veterans Home to perform a physical examination. Multidisciplinary team members are all before telemedicine car to see the patient. All participants discuss about the patient's condition.
好，那接下来部分金正你再做一个所谓的个案的建议。好，就是目前来讲的话，因为
Multidisciplinary team members discuss about the patient's condition and reach the final conclusion. The future direction of TCVH's telemedicine is provide surgical tutoring, intensive care consultation, multidisciplinary discussion and the medication integration to veterans hospital and the veterans home. We hope to increase the ability of surgery and the intensive care of veterans hospital. We also want to reduce inappropriate medication as well as unnecessary clinical emergency room visit and hospitalization. Another part of telemedicine focus inside the hospital. The second outbreak of COVID-19 happened in the middle of May this year. Due to subdivision strategies, members from Ordinary Ward, Intensive Care Unit, Department of Internal Medicine, Center for Infection Control, Department of Neurology, Center of Cardiovascular, Department of Radiology, and so on. From 10 members in the beginning to more than 15 members online simultaneously. From Monday to Sunday, 7 days a week. We held morning meeting continuously since the outbreak of COVID-19. Not only the doctor's communication, we also promote doctor, nurse, and the patient's relationship during COVID-19 pandemic. We have to find out the unmet need of the isolated patients, including reduction of uncertainty and the fear, shorten isolation duration, and a good communication channel. We use video call to meeting with the family. Doctor can visit isolated patient by video call also. Elder, weak, or disability patient are happy with this video call due to its high resolution and the clear sounds. In the meantime, we established a security cam in every single room with microphone that we can see, hear the patient along with the alarm. Video call can connect patients with their family to reduce the fear and the feeling of isolation. Security cam can monitor the real-time situation of the patient and reduce the risk of fall. We established a line group with the families after info consented, because family cannot be in the hospital during pandemic of COVID-19. We also can communicate with the family, telling them that the patient's condition. During hospitalization, we can provide health education as well as patient's current condition. After discharge, the line group can help registration and serve as a surveillance tool. Application of telemedicine includes doctor-doctor connection, doctor-patient connection, as well as patient and IT technology. Future application of veterans home residence includes health management, location, event, and the emergency call. We can collect health information by wearable devices. We can also locate the patient of the resident by GPS or Wi-Fi signal. When residents leave the restricted area, event can automatically notify the caregiver. Finally, if there is an emergency, the resident can initiate an emergency call from wearable devices also. If we connect the information from wearable devices to our server, the early warning system will monitor the resident's situation real time. If there is something wrong, the caregiver will know in advance. How about the outcome? We complete telemedicine clinical visit at least once per month with 4 veterans home. In the meantime, veterans home complete 363 cases of sonogram image upload and discussed 3 difficult cases with TCVGH doctor. Veterans home also equipped with 5G glasses that can transmit real-time image to TCVGH. The additional benefit is reduction of clinical visit of veterans home residents. The average reduction of clinical visits is 125 visits per month. The estimated saving in medical expenditure is 61,000 new Taiwan dollar. The estimated saving in medical expenditure is 61,000 new Taiwan dollars per month. That is approximately 732,000 new Taiwan dollars every year. Additional benefit 2. We promote healthcare ability of doctor in veterans' home. The increased amount is 1,900 visits in half a year when compared with the previous year. Conclusion. Telemedicine is not in the future, it is now. And Taiwan has the advantage in developing telemedicine due to our strong backup of information technology and the excellent healthcare system. However, there is still some challenge we have to face. That is legislation, security of patients' data, and the lack of traditional physical examination by telemedicine. But we are confident that this should be solved in the near future. Thanks for your listening, and please give us comment.
Thank you, Dr. Liu, for the presentation. It is thrilling to learn from the leading professionals exploring the fields of smart healthcare. Now it is my pleasure to convene all the speakers today to turn on the cameras and join a panel discussion moderated by Dr. Chi Zhenling. For our online audiences, if you have any questions, please scan the QR code on screen and leave your question in the Slido. As you had been reminded earlier, you need to specify which departments or speakers their questions are particular for, since we have 4 speakers. Thank you. Dr. Lin, you may now have the floor.
Okay, sure. Hello, I would like to thank all the 4 speakers for their excellent talks. This session is now open for comments and questions. And just a reminder, please be sure to type your questions into the questions box on Slido. And it looks like we have a few questions here already on the registration. And well, I would like to ask 2 questions to every speaker, each by each, because there are so many questions, and I'm afraid that we don't have time to answer all the questions. So the first question will go to Dr. Karen Larsford. The first question is, how can the latest healthcare models close the service gap between patients and providers? These problems continue to exist even under the IR 4.1 and PQ1. The second question, what do you think is the most significant factor to take the first change in order to build a sustainable digital delivery care? Karen, please.
Thank you, Dr. Lin. Thank you very much. Great questions. I think on your first question, we need to remember that technology is a tool. It's an enabler. And I think that the revolution itself is really about how do you bring care closer to the patient. And so when we're thinking about the use of technology, it's about how do we get that consumer focus. And we're seeing that with innovations like hospital in the home, with home care, with remote monitoring that we've talked about today. And particularly, I remember thinking nearly 10 years ago, witnessing in the US, the advent of new models of care like the Minute Clinic in the shopping centre. That's where the real revolutions are starting to happen, where we see things getting closer and closer to the patient. And COVID has certainly been an accelerator. We gave an award through ACHS in the last year to a fantastic innovation in Australia. One of the hospitals that started to do drive-through pharmacy, hospital pharmacy under COVID. So I think that's where the revolution really is, and the technology is the enabler. On your second question about the most significant factor in terms of making that change, I think, as I've said, the technology is important, but really the first step is making sure that you have good standards in terms of the way in which you deliver the safety and the quality of your care. And that means making sure that you've got policies, processes, and your practices absolutely aligned with safety and quality. And so it is important to have standards for telehealth and to make sure that you're using up-to-date information for that care delivery.
Thank you, Karen. And the next two questions will go to Dr. Guo. The first question is, what efforts should be made to prevent or avoid fragmented and the discontinuous of care, especially for patients with chronic disease during the transition of care? And the second one is, what do you think about the medical AI future for Taiwan player? Dr. Guo, please.
Thank you. About the first question, what effort to make to prevent or avoid fragmented care? I think, as in my talk, there are three important issues. First is about the exchange of medical records between hospitals. That means the notes of the physicians and the laboratory test result or even images. And we need a standard format such as a FHIR file to exchange between the different systems. But currently in Taiwan, there is no such standard format or regulations. So I think our government or the medical centers should make efforts to make this standard exchange format. The second point is that we need a communication platform between the doctors, or doctors in the hospitals and in the local GPs, because sometimes the medical records were not enough. Maybe sometimes they need direct communication by the phone calls or by some communication platform or by the text chat. And the third is that about the make appointments of the patients. And in my hospital, the platform could let the GPs to make appointments to our hospital. But in the opposite direction, we cannot make appointment for the patient to the GPs. So that's my answer for this question. And about the second question about medical AI, I think first, from the viewpoint of a physician, I think all decision support systems are needed and welcome because they could help the diagnosis and treatment, and they could decrease the medical staff workload and even avoid mistakes of human. And the second is that the AI, the medical learning, needs big data. Therefore, it needs cooperation between hospitals. That is by the data sharing to get more data to do the machine learning. But most hospitals don't want to release their data to the outside. Even the data are already de-identified because the medical data are very private and sensitive. A potential solution for this is called federated learning. So I think in the future, the medical AI should depend much on a federated learning. That's maybe a direction to develop. And thank you. That's my answer.
Thank you. And next two questions will go to Dr. Liu first. Sorry. And the first one is HIPAA compliance for telemedicine in developing countries is it beneficial? And how a comprehensive virtual primary health program can change the health outcome? Actually, that is the first question. The second question is what kind of new model of telemedicine will be developed in the future? Do you have any idea?
Sorry. Thank you, Dr. Lin. I think the major outcome will be change is the satisfaction. Imagine that the entire clinical visit can be done from wherever, whenever. All you need is a smartphone, tablet, or laptop. No need to leave work earlier to beat traffic jam on the way to the doctor's office or waste time sitting in a waiting room. It will increase the satisfaction of the patient indeed. In addition, a holistic approach to primary care can also be achieved. Imagine that the patient asks a question that the primary care physician cannot answer. The primary physician can call his or her team member to join the chat room for discussion. That means the patient doesn't just get access to a primary care provider, but the whole care team that really takes the time to listen and get to know every unique person. Every patient gets a personalized experience with their needs at the virtual primary health care program. It isn't the best part. Your entire care team is always available through the app, through the program. Video chat with your clinic from anywhere. Message your health guide with a quick question to send a photo or request a prescription refill in no time. It's the most convenient way to get the care you deserve. Virtual primary care maintains the best part of the important relationship formed in traditional care, but takes it even further with state-of-the-art communications technology for refreshing convenience and personalized service. However, there are some things that virtual primary care cannot do, including physical exam, just as I mentioned, laboratory tests, and so on. Nevertheless, through IT innovation, I think it should be solved in the near future. And for the second question, what kind of new models of telemedicine will be developed in the future? I think telemedicine will become an efficient option for preventive care. It is estimated that chronic diseases which are avoidable through preventive care service account for about 3/4 of the United States healthcare spending. By offering more convenient access to follow-up care, specialists for faster diagnosis and telemedicine treatment, hospitals will demonstrate fewer readmissions, complications, and inpatient stay, and reduce the higher cost treatments and the services. The goal of the future care is preventive and to make as many adjustments early on. How do you do that in a cost-effective, time-effective manner? Sure, with technology and the telemedicine services. Another model, as I mentioned previously, access to specialists will become the normal, which will shorten hospital waiting time. There will be specialty centers where hospitals can call in and have 24 hours a day, 7 days a week, access to a network of physicians who are expert in their specialty area, with immediate access to a wide range of physician specialists. These facilities can offer patients expanded access to focused care. In turn, this will improve the overall patient-doctor experience, patient-doctor relationship, and the patient experience. It also reduces the cost of hiring full-time staff on site. In the past, doctors would tell the patient, You need to see a neurologist. Here's the number. Now, the doctor can say, you need to see a neurologist. Let's connect it with one now. As technology innovations evolve healthcare and the patient expectations, preparation become more critical. Telemedicine is here to stay and is easier than ever. That's my answer. Thank you very much.
Thank you, Dr. Liu. And there are a few questions. Is going to Dr. Lim Park. Because your specialty is psychiatry, and so what do you think the major hurdles in achieving smart hospital facility? Is it staff? It is underdeveloped technology, or it is cost? The second question: what are the major The second question is, what measure would you take to ensure that patients receive accurate diagnosis through telehealth? I think it's quite a problem in mental health care. And the third one is, during the COVID-19 pandemics, do you think that telehealth indeed help to prevent mental problems? 3 questions. Dr. Lin. Your speakers, please.
Can you hear my voice?
Yes, right now, yes.
Okay.
Yes.
I would like to answer the 3 questions in one, because I believe in the future, and now it's ongoing in Europe. People start to work in home, and they refuse to go back to the office because it can have a much more good life quality. Just as the previous doctor has reported, they can save the traffic times, they can save the time for lining up in front of an OPD. And all the problem is now facing us is that we are just not, people dislike to change their habit, especially the doctor in the hospital, because when we use a new technique, the doctor have to face a lot of technical problems in the using the telemedicine. But I believe in this week, in this month of experience, the future is the telemedication, because it can help a lot of things to work out. The preventive medication is very good in using this. As I said before, in psychiatry, we can prevent a lot of explosive psychotic symptoms to explode before it happened. And also, talking about the diagnosis, is this true or is this not true? Especially in psychiatry, we diagnose patient by using the history report by the patient family or patient to act as important information of diagnosis. I always tell the student that it is a very rough way to collect information. But if you can use the cell phone, we can read and we can record a video of what's happening in the family, in the episode of the psychotic symptom. It is much more better by verbal report of the patient's symptoms. So I believe that it is much more better and improved to the psychiatrists in the telepsychiatrists. And finally, we can follow up the patient online, and it can save a lot of time before the symptom become much more worsening. So in the conclusive idea, I believe that it is the new way, and it is the only way to improve the TP, the telepsychiatrist, by using the internet. That's my answer.
Okay, thank you, Dr. Lin. And there are a few questions. I have to say that I'm only a moderator, but it seems that the 3 questions are headed to me. I will read it for you. How to make hospital more effective and efficient. The first question. The second one, how to balance the cost and quality in healthcare services industry during the outbreak. The third one, about the human resources needed. Actually, I can give only a very simple answer to all these three questions. I think we need a smart leader who has sophistication and the professionalism. And then we have a very smart team who can cooperate together. So I quote, nothing can be achieved without collaborative efforts. So maybe we can discuss later. Then I think we can go back to Karen. Karen, is there any tool that we can use to assess existing hospital position to achieve smart hospital condition in order to make a strategy to complete all the criteria? And then another question is, how we manage a good and effective communication as a leadership?
Thank you, Dr. Lin. The first question, look, the most important thing there is making sure that you are assessed against appropriate standards. So as a hospital, to really see where you are at and how ready you are, looking at Telehealth Standards is a great place to start. And one of the ways many hospitals start this journey is through conducting a gap analysis, potentially having an external group like ACHS, for example, doing a gap analysis with you and looking at how your hospital stands up against the established criteria. Your second question, Dr. Lin, I think is a really important question and helps to set the tone for success in any change strategy. And I think the key there is how leaders set a strategic vision for an organisation, and then most importantly, how they communicate that vision throughout the whole organisation. I've been lucky enough to spend time in many high-performing healthcare services throughout the world, and it's really the leaders who are effective that communicate that strategy and that direction clearly to the whole organisation and then engage everybody in coming on that journey.
Okay, thank you. Well, look at this. It seems that all the questions have been discussed. I wonder if any speakers would like to ask a question to each other. Is any question?
Dr. Lin, I see one question that's come through from your team.
Sure, yes.
Directly to me. Is there any policy in the Australian government, especially from the Ministry of Health, about accreditation or quality improvement?
Okay, good.
I'm happy to answer that. Yes, accreditation is mandated in Australia by the federal government at a national level. So all healthcare services need to be accredited, and quality improvement is obviously the aim. So recommendations that come out of that accreditation process are used to drive quality improvement.
Okay, good. Thank you very much, Karen. Thanks for Janet to remind us.
Yes.
Okay, any other questions or any question to each other? Or maybe all the speakers can give us the final comments on today's topics. Is that okay? Yes. Karen, would you like to start?
Thank you. And I wanted to thank JCT for the invitation to be with you today and to speak with you. I wish it was in person, but lovely to be able to hear the other speakers. Look, from my perspective, safety and quality is the absolute important bottom line. And so we may use many different tools. We may help to revolutionise healthcare, and I hope we do. Because I think we've seen, many changes in other sectors in our lives, many things that we are used to in banking and in other parts of our experience. We want to make sure that care is still safe, quality care, no matter how it's delivered.
Okay, thank you. And how about Dr. Guo?
I'm glad that I can join this meeting today, and I also learned a lot from our speakers. And I would like to say that by the information technology, we can make a seamless transition of our patients. And so we are all still making progress. So maybe we can develop more IT technologies to achieve this goal. Another thing is that I'm glad that today there is some audience asks the question about AI. We know that AI is an important thing, and we need AI to facilitate to help our medical workings. So maybe in the future we may have another chance to discuss about the AI in the medical field. Thank you.
Thank you. Then Dr. Lim.
And I believe that I have learned a lot from this conference, and hope that in the future we will be using the new technology to have a much more reality, or maybe in 3D virtual life, to have a new conference, and wait for this.
Okay, thank you. And Dr. Liu?
Yes, thank you for the invitation of the JCT. I'm glad I have this opportunity to share our experience with all of you. And I think the telemedicine can assist the hospital in the rural region to improve their healthcare quality. And I also suggest that maybe the artificial intelligence can assist it in the incident report. Maybe we can search the medical chart record and to find the crew to prevent the medical incident. Is there any chance? I think. Karen, do you have any idea, or is Australia have this idea to search the electrical medical record to find out is there any incident or near miss in the near future?
It's a really interesting area. We are definitely looking at predictive analytics and thinking about how we can use machine learning. I think it's early days, probably just like everywhere, but we're involved in a research project at the moment in Australia with our digital health research cooperative at a national level, looking at how we can pull information real time from the electronic medical record within hospitals, and to be able to use that to look at quality issues in real time.
Thank you, Karen.
Thank you, Karen.
Yes, great. Actually, JCT, Taiwan, and Australia have been cooperating for several years I think it is in such topics, and I think we have get some improvement, and I hope the cooperation will keep on, and in the future we have more to share to everyone. And
Absolutely.
I think today's talk, I would like to appreciate all the excellent talks sharing from 4 speakers, especially Karen from Australia. It's almost dinner time. I'm sorry that keep you hungry. But however, I think most of the audience are even more hungry because we are hungry for knowledge. But however, if the knowledge, medical knowledge, cannot apply to a patient, then the knowledge is not wise. And if the artificial intelligence cannot apply to the healthcare, then it is not smart. So I think we all talk about artificial intelligence, but we have to say that it is the augmentation of human intelligence. So human factors are very important. So we have to find out the unmet needs and to find the solutions. And all the solutions should be think over from time to time and to revise to a better solution. So I think this is the core value of our webinar. So here I would like to thank all the audience for sharing with us in the webinar. I appreciate you being here, and due to the time limit, if there are still some questions unanswered or untyped, you are welcome to contact HST to arrange further discussions. Smart healthcare requires integration of healthcare services and the technology applications. It involves cross-industry process and the multiple service providers. In terms of personal training and the process re-engineering, JCT, as a professional accreditation board agency, holds a leading position in improving healthcare quality and the patient safety. We have launched JCT Quality and the Safety Program, which can provide hospitals with customized training courses. You are more than welcome to consult us for the program. And I want to thank you for joining us today. This is the end of today's discussion. I hope that today's sharing and discussion can bring you some ideas in clinical applications. We will see you next Friday on October 29 for session 2, addressed on resilient operational excellence to maximize capacity. Bye bye. 再见.
See you.
Adios. Auf Wiedersehen.
Thank you, Dr. Lin, for moderating this rewarding panel discussion for us, which concluded our forum today. Our best wishes go to all the speakers and the participants.
Thank you.
Ladies and gentlemen, your feedbacks are really important to us, which will help us to improve the quality of events. Please scan the QR code and fill in the foreign satisfaction survey. We appreciate your valuable comments and fully support. Please stay tuned to Smart Life on smartcityonline.org, the TW, for the latest trend in sector innovations. The next session of International Smart Hospital Leadership Forum 2021 is forthcoming. It will be held at 2 p.m. to 4 p.m. on 29th October 2021. Please be sure to register next week's session by scanning the QR code. Thank you once again. Until next time. Goodbye.